First, I would like to start my talk with explaining toxidromes, how to recognize and how to react, and then how to rescue the patient. So we'll move on to the talk with the case scenario. Now a 36-year-old male has presented with a history of aggressiveness, and he complained that someone is coming to kill him, and he's started picking things on the air when during the examination. He was confused, agitated and combative also. And he has got a temperature of 38.9 degrees, and he's having a very dry skin. When you looked at the pupils were dilated with a pulse rate of 108 and high blood pressure as well. And his bladder was actually palpable. So in this, when this type of patient comes, we need to know a few things. First of all, we ask, look and do, and then we go on to the management of this critically ill patient with ABCD approach. And in a toxicological patient, there's a pathway called RESIS pathway. You all know what it stands for. RESIS is for resuscitation, risk assessment, supportive care, investigations, decontamination, enhanced elimination, antidotes, and disposition. So while concentrating on all these things, we have to know what the patient is having. So we need to do some approach. So the toxidrome approach is the best in such a patient. So you have to have a look at the eyes, pupils, skin secretions, vital signs and mental status to see what a toxidrome is. So let me explain a little bit more about that. So as a clinical syndrome, it's again a constellation of clinical symptoms and signs with a class of toxin. So usually it's based on autonomic effects the toxin is causing. And the beauty of this is actually it's a clinical diagnosis. So you can look at the pupil size, skin secretion, vital signs and the mental status to reliably identify the toxidrome. Since different classes of toxidromes actually cause different autonomic features, this will allow a rapid narrowing of the toxicological differential. So, as you are aware, there are 5 important toxidromes: cholinergic, anticholinergic, sympathomimetic, sedative, hypnotics, and opioids. And there are 2 other, serotonin and neuroleptic malignant syndrome also. So, we'll see how to diagnose one by one. This, the next slide is actually to complete the diagnosis. There are a few other things also that you should do. Take a history, ask and have a look at the patient's findings, clinical notes, with suicidal notes. So all these things are important when you are taking a history, and there are some investigations that you have to do. The arterial blood gas comes to the top, and since this patient is having, sometimes you might have to do a CT brain if needed and other investigations accordingly. So moving back to our patient, now see the patient's vitals, the pupil size, the secretions. So have a note on all these things. Then we'll move on to this pathway. So actually this is a very easy clinical pathway that you can apply to all the patients. Now if the patient is agitated, such as in the case of our patient, see the patient is agitated, then this pathway is the one you have to take. Okay, so you look at the blood pressure, pulse rate and the temperature and the respiratory rate, and then look at the pupil size. Now up to here it's the same. All right, so dilated pupils, the only thing that we can differentiate between the anticholinergic toxidrome and the sympathomimetic toxidrome is the skin secretion. So if it is a dry skin and dry secretions, then it point towards the anticholinergic toxidrome. And if the skin is wet and diaphoretic, as you are aware, now the patient is having in a flight and fight mode, then it's a sympathomimetic toxidrome. So you can easily differentiate between the two. All right. So if the patient is agitated, most of the time it belongs to one of the other toxidromes, anticholinergic or sympathomimetic. So if the patient is somnolent, drowsy, then you look at the blood pressure, pulse rate and the temperature. Now if it is normal, then you look at the respiratory rate. If the respiratory rate is usually both depressed in opioid and sedative hypnotic toxidromes, as you're aware. So more depressed in a opioid toxidrome. Then you look at the pupils. Usually the pupils are pinpoint in opioid toxidrome. So therefore, you can diagnose an opioid toxidrome. And then if the patient is having normal size pupils, usually it can be sedative hypnotic toxidrome. But there can be exceptions, please remember that, especially in the case of midazolam. If the patient was given midazolam, then there can be the patient might have small size pupils in a sedative hypnotic toxidrome also. So that has to be borne in mind. And if the patient is somnolent and drowsy, patient's blood pressure is low and the pulse is also low and low temperature due to diaphoresis. And the respiration is also reduced. And if the patient is having pinpoint pupils with wet skin and diaphoresis, copiously wet secretions, pouring out secretions from everywhere, then it has to be a cholinergic toxidrome. All right, I think you can apply this simple pathway to basically clinically diagnose the patient is having. So this is the summary of all the toxidromes that we have just talked about. You can see anticholinergic and cholinergic both having the same sort of, clinical findings, just that the skin is very diaphoretic in the sympathomimetic, and the opioid and sedative are more or less the same. And the cholinergic actually is the opposite of anticholinergic toxidrome. All right. So let's move on to the separate toxidromes and just discuss a little bit about each toxidrome. And anticholinergic toxidrome, as I told you earlier, that there are common causes. Now, in the organophosphate poisoning, as you are aware, it's a cholinergic toxidrome, and when you will be giving atropine. So once the patient gets atropinized, then the anticholinergic toxidrome can occur. So common causes are atropine, plants like datura, and there's another plant called angel's trumpet. Poisoning is very common. Mushrooms, tricyclic antidepressants also a very common cause, antihistamines, anticonvulsants, antipsychotics, and so on. And this small poem will be very useful for you to remember the presentation. Hot as a hair, dry as a bone, blind as a bat, red as a beet, mad as a hatter, and full as a flask. So this is a common mnemonic or a poem that you can remember to you can keep it in your mind to remind the symptoms. And when you go for the treatment, first you prevent the rhabdomyolysis with lot of IV fluids, agitation, benzodiazepines. Physostigmine also, it's the antidote, but we will use it very sparingly if the patient is having seizures, sedation, and very delirious with narrow QRS complex tachyarrhythmias, then you might have to use the physostigmine. Otherwise, we use it very sparingly. And the next one is the sympathomimetic toxidrome. So as you're aware, tremors, rhabdomyolysis, chest pain, the patient can complain, and usual causes are amphetamines, methamphetamines, MDMA, and so on. And again, the supportive care is very important to treat hypertension, and you might have to avoid pure beta blockers. Please remember that. And sedation is necessary. Benzodiazepines you have to use. Again, you have to monitor for end-organ ischemia because MI and CVS are very common. All right. And the next one is a sedative hypnotic. So the common causes are alcohol, benzodiazepine, barbiturates, baclofen, and other chloral hydrate, paraldehyde, and so on. And again, you have to remember that you have to protect the airways in these patients. Make sure that you give enough supportive care and avoid flumazenil if possible. Flumazenil is the antidote because it might precipitate the withdrawal or intractable seizures. So if you give it, so it's 0.2 milligram IV as a stat dose or 0.1 to 0.4 milligram per hour infusion. The opioid toxidrome, again, common causes, heroin, morphine, codeine, and oxycodone, and so on. Again, the naloxone you have to give. If you are in doubt, you can give it and see also. You can give a bolus, and then again an infusion might be needed, 2/3 of the initial dose per hour infusion if the patient is not conscious. And here you might have to do the assisted ventilation, intubation, and so on. So the last one, actually, the cholinergic toxidrome. I'm not going to spend much time because I'll be discussing this in my next few slides. The common causes are the organophosphate insecticides and the carbamate also. There can be Alzheimer's medication overdose, donepezil, or the agents used for myasthenia gravis, neostigmine, and some mushroom poisonings also can cause cholinergic crisis. So please remember that this beautiful mnemonic, dumbbells or sludge, for you to remember all the features which will give rise to cholinergic crisis. It's easy because, as I said, in what happens in cholinergic toxidrome is there will be secretions pouring out from every orifice. So urination, diaphoresis, diarrhea, bronchoria, bronchospasms, bradycardia, emesis, and lacrimation and salivation. So it's easy for you to remember all these things. And we'll discuss a little bit more on the management while we are discussing the organophosphate poisoning. But remember, atropine has to be given in adequate doses, otherwise you will actually make the patient more they will end up in aspiration, and there will be a lot of complications if you don't atropinize the patient properly. We'll discuss about the PAM also in my next presentation. So this is the summary of toxidromes. So it's the summary, and it's very easy, as I said earlier. Look at the sympathomimetic toxidrome. Patient is agitated. Anticholinergic toxidrome. Patient is agitated, and the blood pressure, respiration, and temperature more or less the same. Eyes, the pupils are dilated. The differentiation factor is the skin, diaphoretic, and dry skin in anticholinergic toxidrome. The same as for the sedative hypnotics and opioids. As you can see, respiration is more depressed in opioid toxidrome, as well as small pupils, and somnolence is common to both. Okay, and the cholinergic is quite the opposite of anticholinergic toxidrome, where the heart rate and the blood pressure is low, respiration is low, temperature is low, small pupils, miosis, and copiously wet skin with the somnolent features. Okay, now the last slide of mine. Now we will be talking about serotonin syndrome and neuroleptic malignant syndrome a little bit. Again, these two syndromes, it's difficult to differentiate, but there are few things that you can actually use. All right, the main thing that you have to know is that usually serotonin syndrome is very rapid in onset. Within 24 hours it can occur. And the neuroleptic malignant syndrome, on the other hand, is very slow to develop. It takes days to weeks. And when you look at the CNS findings, there's hyperreflexia in serotonin syndrome, and it's the other way around, hyporeflexia in neuroleptic malignant syndrome. So those are the vital things that you have to pick. And the pupils also, pupils are mydriatic in serotonin syndrome, dilated. Usually it's normal in neuroleptic malignant syndrome. So these things are actually, you will be able to differentiate between the two syndromes. And again, serotonin syndrome, it resolutes within 24 hours also. But on the other hand, neuroleptic malignant syndrome takes days to weeks. All right. So the muscular rigidity is also more severe, lead pipe in neuroleptic malignant syndrome. So these are the differentiating features. I hope that you have got some knowledge about, how to assess and how to analyze a patient who is coming with an unknown poisoning and a toxidrome. Okay, thank you very much.